Ladies and gentlemen, thank you for being here today. It's fantastic we're here, finally, surgery. We kind of take surgery for granted a little bit. It's sort of always there in the background. I've got a privilege and the honour of actually presenting work that's actually the product of nearly 44 different commissioners, 60% of whom come from low and middle income backgrounds. It's a huge piece of work. It took a couple of years to complete, and this actually comes out of the foundations of some work many of you will know about, which was the Global Surgery 2030 Commission that Lancet prosecuted and published this year. And in it, it identified two key areas for further work. One was around trauma and musculoskeletal, and the other area was around cancer. And so today I'm just really going to give you the really top highlights of what the Commission has found. When we talk about surgery, I think it's worth reminding people here, and it might seem a little bit obvious, but we're really talking about surgery and anaesthesia together. We're also, and this is really important, talking about the trinity within cancer, which is surgery, pathology, and imaging. In a sense, we just can't do anything without those. So when I talk about surgery, and I'm sure Ricardo will emphasize this in a moment, this is what we're talking about. And indeed, and just to make the point about radiotherapy and the integration with other areas, we are talking about cancer systems here, and the importance of radiotherapy and actually cancer medicines is essential for developing the systems. So, as Rifat talked about, there was a lot of focus on the economics. We also focused on the economics as well within our piece, but we had really came down to 5 key messages and solutions within our commission. The first thing is that in 2015, 15.2 million people worldwide will be diagnosed with cancer. 80% of those will need a surgical procedure at some point. Diagnostic, curative, palliative, whatever. That equates to about 15 million operations worldwide that will be needed. And colleagues basically have extrapolated this forward to 2030, when this will rise to the need globally of nearly 50 million operations. Now, the biggest rise, and this is the important bit, is not in high incomes. The biggest rise we're going to see is in low and middle income development areas. 59% increase that's going to be needed in those countries. The sad fact is, though, as we found from Global Surgery 2030, from our commission, that today, globally, 3/4 of patients, cancer patients, do not receive affordable, timely, or safe cancer surgery. And that is a huge, huge, and in my view, unacceptable number. This, of course, has tremendous economic consequences on countries. And I'm not going to go into many of the details of the economics. One of the things we did was look forward to 2030 and ask the question, if nothing changes, what's going to be the financial burden? And the financial burden globally is about a loss of $6 trillion by 2030 if the situation does not change from what we have today. That equates to between 0.5 and 1.5% of GDP lost every year in every single country. That's how dramatic the impact is. One of the other areas in the Commission as well we looked at in terms of economics, because it's not just about macroeconomics, is the economics about the families. So this is about affordable surgical care globally. And in the Commission we make various recommendations and show various models for how to protect families from catastrophic expenditure due to receiving cancer surgery. And there are many good models around the world, but still globally, out-of-pocket expenditures and catastrophic expenditure is a massive cause of impoverishment. The solutions, well, first of all, it's about building systems, and this is not a one-size-fits-all. We're talking around nearly 277 different surgical procedures across 6 complexity levels. At least 110 of those require specialist cancer surgeons, so in gynecological oncology, urology, head and neck. So it's different horses for different courses. The first thing we call for is, of course, to have surgery integrated into national cancer control plans. When we looked at NCCPs, which are out there at the moment, and only about 50% of the countries globally have national cancer control programs, only 9% of those programs actually ostensibly have elements that you could identify as developing capacity and capability in cancer surgery. And that needs to radically increase. Within the Commission as well, we talk a lot about the different models globally that people have engaged in terms of education and training. So training the next generation, general surgeons to do cancer operations, and also specialized models. And there are some fabulous models, whether we're talking about urology in Senegal, the models that SO have worked on, a lot of really, really good learning that can be developed globally. The fourth message is around research. And again, we kind of, in the effort to try and develop care and capability, we often forget about the importance of research. The analysis in the Commission shows that globally, the amount of research dedicated to cancer surgery is less than 5%, which is unbelievable, but it's true. Most of the money at the moment goes into fundamental research, and you won't be surprised, medicines, biomarkers. And the reality is that when you look at radiation, surgery, palliative care, we come a long, long way down the list. And even more worrying for the future is a lot of this research is really focused on high incomes. So of the totality of cancer surgical research, only about 17% is relevant to a lot of the emerging and low-income economies. Massive deficit in research needs. And finally, the final message, and I'm going to echo the point about the politics here and about being at the table. I think surgeons can sometimes, we can be our own worst enemy in terms of just getting on with things and not being there at the political table. And we've pointed the finger very firmly with some very hardcore analysis at World Bank, WHO, International Atomic Energy Association, the research funders, that when they're talking of strategy, when they're talking of cancer control and systems, they have to have radiation, surgery, pathology, and medicine there at the table all the time. And the days when you just had one or two medical oncologists, say, representing everybody, have long, long gone. And moreover, actually, it's not a matter of sort of high-income countries talking about how emerging economies should be developing their systems. There's a need to bring people who've got enormous expertise in very low resource-intensive countries to the table in terms of putting the politics of cancer surgery firmly on the agenda. So thank you.